Great. Thank you very much for the introduction and for the invitation to join this webinar. It's really a pleasure to be here to speak with you about the management of anemia in pregnancy. So first, what I'd like to do is just to give you a little bit of a background on anemia and the problem of anemia. We estimate that nearly all countries have at least a mild public health problem of anemia, and that's defined as at least a 5% prevalence of anemia. From this map being shown, you can see how widespread it is. With the darker a country is shaded in red, then that is reflective of a higher prevalence of anemia. So you can see the highest burden of anemia for women 15 to 49 years of age is in the areas of Africa and Southeast Asia. And we estimate that globally about 37% of women are of pregnant women are anemic, and about 30% of women 15 to 49 years of age are anemic. And we've been tracking the prevalence of anemia both in women and children for quite some time now. And here's the prevalence of anemia from the years 2000 up to about 2019. That top dark line in red there, that's the prevalence of anemia in pregnant women. The gray line is for non-pregnant women, and that lighter pink line is for both groups combined. And globally, we can see there's been some decrease in anemia over time for pregnant women, but progress, particularly for the non-pregnant women, is not been very great, and we'd really like to see a much more accelerated progress. It was in 2012 that WHO first developed different targets for nutrition, and one of those targets was a 50% reduction in anemia in women of reproductive age. And it was in 2019 that this indicator became part of the Sustainable Development Goal 2.2 on ending all forms of malnutrition. If we look at the progress that's been made in anemia since the starting point of the global nutrition target in 2012, we see that we're really not making enough progress to be working towards those targets, and we're actually seeing a slight shift or an upward trend in anemia for the non-pregnant women. So we have a lot of work to do in order to accelerate this progress. And when we consider the consequences of anemia, we know that it impacts not just an individual, but it impacts also their family, their communities, and the population as a whole. Anemia can have serious health, development, and economic challenges, and these include the fatigue and weakness that leads to exhaustion. It can lead to increased risk of infections, for particularly in pregnant women. It can lead to an increased risk of postpartum hemorrhage or death when the anemia is severe. There are also different poor pregnancy outcomes that's been associated with anemia, including miscarriage, stillbirth, prematurity, and low birth weight. And then for children, it could also lead to poor cognition, growth, and development. And then for the women themselves, it can lead to impaired physical productivity, work performance, resulting in a loss of earnings and productivity for the society as a whole. So we know that we need to do better to understand also the etiology of anemia. It was in 2013 that the Global Burden of Disease had estimated that iron deficiency accounted for about 63% of total cases of anemia. And then other micronutrient deficiencies were also felt to contribute, but their relative contributions is still a bit of a matter of research right now. When we look at an anemia that's due to infection, this is the second most common cause, and it accounts for about 13%. Then there's definitely different variations by setting and context, and many of the infectious diseases are due to malaria, schistosomiasis, and hookworm. But we also know that about 10 or 11% of the anemia has been attributed to inherited red blood cell disorders. And a lot of these are related to sickle cell, thalassemia traits, glucose 6-phosphate dehydrogenase deficiency. And these will also vary significantly by setting as well. And then we also are aware of other conditions that lead to anemia, like gynecological conditions, gastrointestinal disease, and chronic disease. So because there's differences in the etiology of anemia by setting, if we look at just some of the data from 2019 now, just for Southeast Asia, we can see that still the greatest proportion of cases are thought to be due to iron deficiency, with about 54% of those cases. But then the sickle cell and thalassemia traits together contribute to almost about 20%. So much higher prevalence than that globally predicted. And the gynecological diseases are felt to contribute about 7%. But then when we see the proportion of anemia due to infections like malaria, schistosomiasis, and hookworm, they're much lower. So it's really important for us to be able to understand the context. And I'm sure within the region of Southeast Asia, there are probably lots of differences among the countries themselves too. So overall, why do we feel that there's been poor progress towards reducing anemia? We know that there's complex etiology, and the consequences are very wide-ranging due to a variety of causes and biological, socioeconomical, and economical risk factors. And we need to do better about improving the hemoglobin measurement and also how we interpret it, which I'll get to in just a moment. We also need to advocate more for assessing the underlying causes of anemia, bringing data from different disciplines together to help to inform the programs that we deliver. There's also been a pretty poor understanding of the economic or development impacts of anemia on individuals, families, and communities. So we do need to do more work to provide education about the causes and consequences, looking at promotion of gender equality, poverty alleviation, addressing taboos and different negative cultural practices that we feel are also contributing to anemia. There has been inadequate coverage of effective interventions and insufficient coordination of and integration of the program. So as we strengthen the health systems, this is something that we can improve as we bundle different services together through shared delivery platforms. And we also can try to coordinate our efforts a bit more in the investments for research and development that will help countries move towards progress on reducing some of these anemia causes and risk factors. And we can certainly do better at the country or at the global level as well as we work to comprehensively address anemia. So what we've been doing in the past couple of years is what we've been trying to do is facilitate a coordination with developing an interdepartmental working group on anemia. And this includes representatives from nutrition, where I sit, but also in sexual and reproductive health, maternal child health, malaria, neglected tropical diseases. And we're really trying to come together to address anemia more comprehensively. So with partners, we produced some background papers looking at those causes and risk factors, diagnostics, interventions, and programs. And these have led to the development of this comprehensive framework for action on accelerating anemia reduction. And this was published just last year. And in addition, we are establishing an Anemia Action Alliance to bring some of our partners together so we can have a more coordinated and aligned effort to reduce anemia. I won't spend too much time on the framework, but it does focus on a variety of sectors that can contribute to the efforts of reducing anemia, and those are listed at the very bottom. And there's many different sectors. We've also identified 5 different action areas that look at the causes of anemia. They look at the different interventions and how we can prioritize those based on the causes, how we can optimize the delivery of those interventions and services across different platforms and sectors, how we can strengthen leadership, coordination, and governance at all levels, and then how we can also expand some of that research, learning, and innovation. And by doing this, we can have better programs that are implemented for the prevention and diagnosis and management of anemia. And we are working through 4 the main causes of anemia, and that's looking at micronutrient status, the infections, inflammation, chronic diseases, the gynecological and obstetric conditions, and also the management of inherited red blood cell disorders. So all this, we hope that will help us to get to some of those global targets, improve health and wellness and well-being of the individuals themselves. So just a couple of key messages. I have put the QR code for the document on the slide for further reading if interested, but just some of the key messages are that the framework recognizes anemia is cross-cutting. It suggests essential action areas and interventions to address it that are based on country-specific data and available delivery platforms. It does emphasize that all causes of anemia must be addressed, and we recognize that there are been many different efforts that have gone on to address the iron deficiency side of anemia, which is really critical, but these efforts alone are not sufficient, and we need to make sure that we address all causes. And then just delivering on the appropriate interventions as a package. We need to do those together. We need to bundle them as much as we can, and making sure that we achieve effective coverage, particularly at different key life stages, like during pregnancy. And this is really felt to be the foundation for improving health and well-being, as we feel that anemia is really an indicator of health and development. And lastly, addressing anemia comprehensively really demands that strong leadership and collective action among multiple sectors. So now I'll get to just focusing a bit on the management of anemia during pregnancy, and I've included a little bit of information on the postpartum period as well. And here are some of the documents that I felt to be most important that I'll be referring to most. The first is probably what many of you are already very familiar with, and those are the WHO recommendations on antenatal care for a positive pregnancy experience. This was developed in 2016, but there have been multiple updates on key interventions along the way. For nutrition, some of those were in 2020. We also have recommendations on maternal newborn care for a positive postnatal experience. And we have just released guidance on hemoglobin cutoffs to define anemia in individuals and populations, and I'll go through some of the key changes in that document. We also have some older documents that I'll be referring to and that we'll be updating in the next few years as well. But these come from the standards for maternal and neonatal care, looking at preventing and controlling iron deficiency, and then the IMAI guide, district guide for clinicians. So these were important documents that I drew data from. So if we're looking at how we test for anemia, I'm not aware of any specific guidance that deals with postpartum, but for pregnancy, it's recommended that this be done at 12 weeks, 26 weeks, and 36 weeks gestation. So at antenatal care visits 1, 3, and 6. And it's recommended that the testing be done using a full blood count, using venous blood for the diagnosis of anemia. For those settings where a full blood count is not possible, then it's recommended to use a hemoglobinometer, so something like a HemoQ machine for point of care. And then for those low resource settings that are not able to even use the hemoglobinometers, then a hemoglobin color scale may be considered. And it's really emphasized in a number of pieces of work that we've been doing, that developing or investigating other low-cost point of care devices for both hemoglobin and looking at some of the underlying causes of anemia, particularly for iron deficiency. These are really urgently needed, and we're really trying to work with other developers to make sure that these tests get developed and made available. Now, with the ANC guidelines, we always provide considerations for implementation for the recommended actions. And for hemoglobin assessment, these are that we need to know about what methods are locally available to diagnose anemia, and which one is feasible to start with, and how the results should be interpreted and managed. We need to collect the specimens, follow the instructions for the specific method of analysis, and maintain the infection prevention control standards. We need to ensure that there's capacity to conduct the tests, have the appropriate materials in place to carry them out, so all the reagents and the materials. And it's really important that we maintain the quality assurance and quality control for any of our lab tests, specifically for the diagnostics. and making sure that we have the commodities available to be able to treat the anemia. And then there's also a need to consider to switching to a full blood count or to a hemoglobinometer method if it's not already being used. And so those are some of the considerations within the guidance. When we look at how to interpret some of the hemoglobin test results, the new guidelines on the cutoffs for defining anemia have provided some updates on how we adjust the values based on elevation at the place of residency, as well as smoking habits. So these are two factors that really impact hemoglobin concentrations. For elevation, we now have adjustments that start at 500 meters above sea level. And this is a new recommendation because we used to start at adjusting at 1,000 meters above sea level. And there's also a relatively larger adjustment for those that are residing at lower than 3,000 meters above sea level, and then a relatively smaller adjustment for those residing above the 3,500 meter level. So there are some changes in the way that this impacts the hemoglobin concentrations. For smoking, there's no adjustment for non-smokers, but there is a slight change for smokers in terms of the number of cigarettes smoked per day rather than the number of packs per day. And adjustments that are shown here can either be subtracted from an individual's observed hemoglobin level, or they can be added to that hemoglobin cutoff before defining anemia. We also, within our guidance, we also have different equations for each of these two different factors that can be used instead of using the categorical adjustments, but that's all provided within the guidance as well. So when the hemoglobin value is obtained and adjusted if it's needed, then here are the recommended cutoffs for defining anemia and its severity. So the cutoff for pregnancy in the second trimester is that slightly lower, 5 grams per liter lower compared to the first and the third trimesters, particularly for the mild and moderate anemia. However, it's the same threshold, the less than 70 grams per liter for severe anemia for all trimesters. For postpartum, there's no specific WHO recommendation for hemoglobin cutoffs, but I've noted here the cutoffs for women that are non-pregnant, and it's 10 grams per liter higher than that compared to the third trimester of pregnancy. So this is for defining the anemia. And when we talk about the different actions for the prevention and management of anemia, I mentioned within the comprehensive framework, we're really trying to emphasize that multidisciplinary and multi-sectoral approach. And this slide tries to illustrate the different sectors that can play a role and the different actions that they may consider. I'm not going to go over all of these with you today. I'll really focus on the primary interventions that are related to iron deficiency anemia in pregnancy. But I just wanted to make you aware that there were interventions suggested for all different sectors for the prevention of anemia. So if we focus just on pregnancy and postpartum, the nutrition interventions really center around counseling on nutrition, food safety, and healthy diet. And this would include things like dietary modification and diversification, and also food fortification with iron and other micronutrients. We also think about consumption of a daily or intermittent iron and folic acid supplement throughout pregnancy and in the postpartum period. And then we think about preventative multiple micronutrient supplementation. So these are the recommendations for nutrition. And I'll just mention a couple of others that I felt to be important areas for consideration. And again, this will depend on the local context. And those are making sure that we have good treatment for infections like the malaria, tuberculosis, and others, making sure that we are treating for any of the soil-transmitted helminth infections or schistosomiasis, screening and treating the chronic diseases, making sure that we reduce unnecessary C-sections. The pregnancy or the birth spacing was felt to be really important in reducing anemia. And then also looking at the genetic testing and counseling for any of those inherited red blood cell disorders, And for those who are having sickle cell disease, making sure that there's a good management practice in place for those patients. For the counseling on nutrition, it's recommended that there's some level of counseling for healthy eating and keeping physically active during pregnancy. And this is really for the purpose of staying healthy, preventing excessive weight gain during pregnancy, but also making sure that there's an adequate consumption of energy, protein, those vitamins and minerals that are related to anemia, and making sure that there's a consumption of a variety of foods, such as the green and orange vegetables, meat, fish, beans, nuts, whole grains, and fruits. It's really emphasized that these interventions, specifically around nutrition counseling, should be really woman-centered and delivered in a non-judgmental manner. There's lots of different ways that women eat around the world, and so we really need to take those contexts into account. And it's noted that a lot of the evidence on healthy eating and exercise comes from many of the high-income countries, and there's still quite a few ongoing trials in this field. So we do hope to have better guidance about how to implement this recommendation a little bit more thorough. There is some guidance from our WHO European office that might be helpful, though, on healthy eating during pregnancy and lactation. And as there is implementation considerations for counseling also, what we need to do is we need to know about the healthy diet and exercise locally. What are the local practices? What is the prevalence of, I would say, both underweight and overweight and those micronutrient deficiencies that we should be thinking about? We need to provide the counseling, have those counseling skills, and create the time and space for counseling. It's also very difficult to do this, particularly in a busy antenatal care clinic. And then just make sure that we consider different gender issues and cultural expectations of women, some of the pressures that they are under, if there's any local taboos, and any local food security issues that should be considered as well. Now for the iron-containing supplements. It's recommended that all pregnant women receive daily iron and folic acid supplementation. And this is for the prevention of anemia, sepsis, low birth weight, preterm birth. All of the supplementation should contain at least 400 micrograms of folic acid. And then the level of iron can really be anywhere between 30 milligrams to 60 milligrams. And this is dependent upon the prevalence of anemia in that area. If there's a really high prevalence, around more than 40%, it's suggested that you go to the higher range. But I must say this should also be dependent upon the tolerability of the supplements. Usually lower doses of iron are more tolerable for women, so that's also a flexibility as well. For those who are not able to tolerate even the lower dose daily, then there is an option to have intermittent iron and folic acid supplementation. And this can be in the form of once a week dose of 120 milligrams of iron plus 2.8 milligrams of folic acid. And this should really be done carefully, making sure that the women are not anemic themselves. And so we do need to have a little bit stronger of a health system in place in order to be able to implement this recommendation. There's also the option of receiving iron and folic acid through a multiple micronutrient supplement. However, these are currently only recommended in populations that are affected by an emergency and for those who are living with tuberculosis. It's also recommended within routine care, but only under the context of research. And this could be a whole seminar on its own, so I won't get to too much, but just to let you know that that is an option as well. Now, for postpartum, it's also suggested that iron supplementation, either alone or in combination with folic acid, could be provided after childbirth for the first 6 to 12 weeks. And the dose and frequency could either follow that was used in pregnancy, or could also follow that used for non-pregnant women, whichever is preferred. But this is really recommended for those areas where there is an anemia prevalence of 20% or higher. Now, regardless of the type of a supplement that's used, it's really important to establish a quality assurance process to guarantee that the supplement is manufactured, packaged and stored in a well-controlled and uncontaminated environment. There are different communication strategies that will be important for improving the acceptability and adherence to the different supplementation schemes. And there might be a need for reminding women to take their supplements and helping them to manage some of the side effects that are often associated with iron-containing supplements as well. And again, for the implementation guidance, you really need to know that the iron and folic acid is still a recommendation for all pregnant women. There's a need to provide the supplements to make sure that they're available, to do the counseling, make sure that there's time for counseling, and make sure that there's, you can consider different ways of providing this. It doesn't have to be always in the same manner. You can do group-based counseling, task shifting, providing them in the community as well. So there's lots of different things to consider here. And then a few other recommendations that I thought were important to note is the recommendation on the preventive anti-helminth treatment that's recommended for pregnant women after the first trimester for those living in areas where there is a greater than 20% prevalence of infection. So it's recommended a single dose of albendazole or mebendazole is provided to those. This may not be such an important intervention within your region, but what might be more interesting for your region is the screening for inherited red blood cell disorders, because it's noted that there are quite a few different variants of the thalassemia gene that occur in countries in Southeast Asia. And these are affecting the hemoglobin levels and could affect how we provide the treatment in those areas. So thinking about 60% of the population, some of these regions being affected, that's quite a high prevalence and maybe something to consider for the region. And just to note that there's updated guidance coming on screening and management of sickle cell disease in both pregnancy. And that's been underway and should be released in the next year. When we shift to looking more at treatment of anemia during pregnancy, then we have to remember that anemia should never be the final diagnosis. It's really a symptom, and we should always look for the cause. So if I assume that the cause is more related to nutritional or iron deficiency, then the recommendations will really be about that diet and that supplementation. So right now we have recommendations to increase the daily iron content to 120 milligrams in the supplements until that hemoglobin concentration rises to normal. And then thereafter, you can resume with the standard preventative dose. It's also good to advise on the consumption of different iron and vitamin C rich foods. This will also help. And then those with severe anemia, really making sure that they get some close follow-up, suggested 2 weeks after supplementation is started, in order to look at compliance and looking at response to that supplementation. And if the response is either insufficient or if there's any respiratory or cardiac distress, we really should be referring those women to a much higher level of care. Now, depending on also what are the other nutritional deficiencies that are happening for these women, there could be B12 provided either as an oral supplement or intramuscularly. We can provide higher dose folic acid, and then you can also provide some vitamin C as well that are higher dose. Now, the use of intravenous iron for treating anemia in pregnancy has really exploded, I must say, in the past several years. And WHO guidance on this is not very recent. It dates back to the late 1980s, where it was recommended that only it's provided when oral administration is not tolerated or in cases of persistent non-compliance of supplementation. And in these cases, 500 milligrams of iron given in 10 mils of saline within a hospital setting was recommended. Now, since the 1980s, there's been so many new formulations of intravenous iron that are on the market, and this has really driven an increased use in middle and higher income countries, I must say. And these formulations are really typically used or licensed only for cases of iron deficiency anemia. So really making sure that there's a indicator of iron status that is measured before their provision is important. And we know that there's many trials that are ongoing, and we had a consultation last year that starts to look at some of the evidence, starting to understand the challenges around the different types of formulations, when and how to give them. And we're watching these trials very closely, and we should be having some guidance out there in the next few years, and I'll talk about that at the end as well. Now, for blood transfusion, it said that anemia in itself is not an indication for a transfusion. There's no common threshold for hemoglobin that indicates transfusion is necessary, and there's no real goal hemoglobin to attain. It's really should be based on the symptoms and the functional status of the patient. But consideration, I must say, is often given to patients, with hemorrhage associated with shock, with severe malaria, and with a hemoglobin less than 70 grams per liter, and those with thalassemia major. So we have to remember that even within an individual, anemia may be the result of several different causes. You could have the nutritional anemia that has been driven by the infections, could be HIV, could be malaria, parasitic infestation, even cancers, malignancies. But it's really important that we start looking at some of these underlying causes so we can treat the cause and not just try to treat the iron deficiency. So when we look at some of the guidance within the district guide, there are quite some specific clinical guidance for patients that are presenting with pallor and anemia, and there's many different approaches that are listed based on the cause. And I thought this is really important at that patient level to be able to consider. There's guidance about the additional tests, the classifications of anemia, and the approaches for the management too. So I think it's really important to have a look at this if this is of interest for you, to see the different types of anemia and how we would treat them differently. So as I mentioned, some of our guidance on the management of anemia is quite old for pregnancy. So right now we are working to develop a comprehensive guide looking at the diagnosis, prevention, and management of anemia during pregnancy and postpartum. This will include not just the nutritional side, but all the other causes of anemia as well. And we expect to probably start with some of the iron deficiency anemia because of those, the updated guidance that's needed for intravenous iron and supplementation of iron particularly. But it will be a rolling release of this in the next years. And then, as I mentioned, the Anemia Action Alliance is being established and really trying to get partners and countries together to foster different coordinated efforts to reduce anemia and to support the implementation of the comprehensive framework. So if there's any questions at all, happy to receive those. Happy if you reach out to me with anything additional too. So just thank you for your attention, and I look forward to the next presentation.
Thank you. Thank you so much, Dr. Lisa, for your insightful presentation. You broaden our knowledge with all the details and comprehensive information on the prevention and management of anemia in pregnancy. Dear honorable attendees, now let us move forward to the second part of the agenda. Again, it's my honor to introduce our next speaker, Dr. Mariana Widmer. Dr. Mariana Widmer is a biochemist by training with a focus on improving the health and well-being of women during pregnancies. Since 2002, she has committed her career to maternal health at the WHO, showcasing substantial expertise in clinical, epidemiological, and implementation science research. Dr. Mariana has played a pivotal role in coordinating and managing large-scale epidemiological and clinical trials on critical issues like infection, preeclampsia, obstetric fistula, with the growth in postpartum hemorrhage. In recent years, her portfolio of work has focused on improving health outcomes for mothers suffering from postpartum hemorrhage. Additionally, she is actively engaged in enhancing the quality of maternal medicine accessible to women in low and middle income countries, thus contributing to overall improvement of maternal and newborn health. May I cordially invite Dr. Mariana Widmer to kindly deliver the WHO recommendations on prevention of postpartum hemorrhage. Dear Doctor, may I invite you to the floor?
Thank you. Thank you so much for the introduction. And it is a pleasure for me to be here today to present the WHO recommendations on prevention of postpartum hemorrhage. Next, please. So let's start with the definition of postpartum hemorrhage. What is PPH? PPH is defined as blood loss of 500 mL or more within 24 hours of delivery. It is indeed the leading cause of maternal death worldwide. And based on the last estimates, we know that 27% of the maternal deaths are due to severe bleeding. What is important to know is that the majority of the PPH-associated severe morbidities and deaths could be avoided by the use of prophylactic uterotonics during the third stage of labor and appropriate management. This means that if we want to achieve universal health coverage and ensure healthy lives, we must ensure accessibility and sustainability of good quality uterotonics, and we have to train health workers on how to manage PPH. Next, please. So there is a widespread problem with the quality of uterotonics used in low and middle income countries to manage PPH. So access to quality of medicines is a human right. And access to medicine is one of the fundamental elements in achieving the right of everyone to the enjoyment of the highest attainable standard of health. We did a systematic review in which we looked at the quality of uterotonics used for managing PPH, and we found that 75% of the ergometrin, 39%, almost 40% of the oxytocin, and almost 40% of the misoprostol were of substandard quality. And we are very worried about this because, as the guidelines say, the only way to prevent PPH is using a good quality oxytocin and misoprostol in case there are not skilled healthcare attendants present. Next, please. So these are, in 2012, we published the first WHO recommendations on PPH prevention and treatment. Then the new evidence came, and in 2018, we had to update these recommendations on PPH prevention, mainly the part of related to uterotonics, the use of uterotonics. So in these recommendations from 2018, we said that in settings where, so sorry, I think this is not the presentation, but again, I will continue. So what we said is that you need an uterotonic to prevent PPH. And the uterotonic, the gold standard is oxytocin. So oxytocin is the gold standard, is the uterotonic recommended for PPH prevention. Now, part of the recommendation says, if you don't have oxytocin in your place, either because it's not available, because it has substandard quality, then you can use other injectable uterotonics. You can use carbetocin, or if appropriate, ergometrin, methylergometrin, or oxytocin, ergometrin fixed dose combination, or oral misoprostol for the prevention of PPH. Next, please. So we are saying in the recommendation, you can use oxytocin, but if it's of good quality. But how to know that this oxytocin is of good quality? It's very difficult for a healthcare provider to know if it's good quality or not. So first of all, you need to know if that oxytocin has been WHO pre-qualified or has been registered by a recognized regulatory authority. Then the oxytocin, if you look at the ampoule, has to be labeled for storage at 2 to 8 degrees Celsius. Or you can also see if the oxytocin has been all the time in the fridge. So oxytocin has to be all the time in the fridge in order to keep the activity. So the health system stakeholders need to ensure that the manufacture and the cold chain transport and storage of oxytocin is sufficiently rigorous to ensure good quality. Now, one thing, here I'm talking about oxytocin. Similar is with misoprostol. Misoprostol, you will see then that it's recommended in cases where you don't have oxytocin or where you don't have a skilled health provider to give the injection. Misoprostol needs to be protected from humidity. This means that if you see that misoprostol tablets are all around the place outside their packaging, it's very likely that that misoprostol will not work because it will be affected by humidity and it will lose activity. Next, please. So I'm insisting on the storage conditions of the uterotonics that you need to use. And specifically for oxytocin, ergometrin 2 needs to be in the cold chain. We did a study in which we look at all the labels of the oxytocin that were in South Africa, in South African countries. And we found that most of them, they were labeled to be kept at 25 degrees Celsius or storage or room temperature storage conditions. And this cannot be approved by regulatory authorities. This is not possible because stability data shows that oxytocin and ergometrin cannot stay outside the fridge. Next, please. So, because we identified this problem in most of the low and middle income countries, we decided to publish a joint statement with UNICEF and UNFPA to highlight the importance of the appropriate management of oxytocin for maternal health. Then we also produced a document for regulators to guide them on how to assess the dossiers presented by manufacturers for approval. Let me say that now we are planning to do something similar for misoprostol, because again, everybody thinks misoprostol does not have quality issues because it's heat stable, and actually it has the same quality issues as oxytocin and ergometrin. Next, please. So, which are the consequences of providing a substandard uterotonic? First of all, we will not be able to implement the recommendations. Second, we will put the women at a higher risk of having postpartum hemorrhage. We will put the women at higher risk of having cesarean section because, as you know, oxytocin is used also for induction augmentation. But we are putting the risk also on the woman of having an overdose of oxytocin, for example. So we did, again, a study in which we looked at the perceptions of the healthcare providers on the quality of the oxytocin they were using and the consequences of that perception. And many of them, they said that because they knew that oxytocin was not working, they gave double or triple doses of oxytocin without knowing if it was good quality. Or they saw that they have more cesarean sections, of course, because the oxytocin is not working. So this is to show the importance of being confident with the uterotonic that you are using. Next, please. So, if I want to summarize the WHO recommendations published in 2018, I would say, I created this graph to walk you through. Let's see. So if in your place, you have all the recommended uterotonics available. By all recommended, we know that they are oxytocin, carbetocin, ergometrin, misoprostol. You have all those. You also have a skilled health personnel available that can provide an injection. Then you know that your oxytocin or your ergometrin or oxyergo were stored continuously in the cold chain, then the first choice is oxytocin 10 international units, IV or IM. But you can also use carbetocin, heat-stable carbetocin, ergometrin, oxyergo, or misoprostol, 400 or 600 micrograms. Now, again, you have all the recommended uterotonics, you have the skilled health personnel available, but you know that your electricity system is fragile. And you know that all the oxytocin, ergometrin, all these medicines, they suffer these electricity cuts. So you will not use oxytocin, you will not use carbetocin, but you will use heat-stable carbetocin, which is very similar to oxytocin, but can stay outside the fridge. Okay? Then, and you can use also misoprostol. Now, if you have all the recommended uterotonics, but today the skilled health personnel is not available, then the only option to go with is misoprostol, 400 or 600 micrograms. Next, please. Okay, so this is briefly for treatment. Today we are discussing prevention, but this is to say that the same uterotonics are applicable for treatment, except for carbetocin or heat-stable carbetocin, that it's only recommended for PPH prevention. Next, please. So we have implementation barriers because we don't have quality of uterotonics. Sometimes we don't have health providers that can administer injections. We may not have the products in place to administer the uterotonics. And as I said, we strongly recommend the use of uterotonics for the PPH prevention. So in general, we see that there is a lack of quality of PPH drugs throughout the health systems. There is a lack of innovations in this area. So we only have heat-stable, we have the heat-stable carbetocin, which is an injection, and we have the misoprostol. We don't have other options for places where we don't have a cold chain. Then the accessibility is also an implementation barrier to our recommendations. So there is an irregular last mile distribution. There is a low uptake of new products because there is a lack of awareness among the stakeholders. And there is a lack of updated national PPH policies and guidelines. So this is why I'm very excited to have this webinar today to show you and to discuss with you what we recommend for PPH prevention. Next, please. So, which are the potential solutions? First of all, we have to raise awareness. We have to train, we have to talk about PPH. What is PPH? How we can prevent so people are not scared of PPH. We need to inform, and training is the most important. Then we need to look at the medicines. We need to be assured that they have the hospitals or communities, they have access to good quality of medicines, that these medicines are properly stored and they are properly given to the patients. We need to have the WHO recommendations at hand so we can train and we can update the local policies. And of course, we need to be attentive to innovations coming. It is very important in all these to include the civil society. So including patients' representatives, including communities, to understand the problematic and to, let's say, join forces to really be able to provide the recommendations and the uterotonics that we need. It's paramount. We also need to engage with policymakers, of course, with health personnel, But also we need to tackle at the supply chain level and at the regulatory level, at the ministerial level, so they can understand the problematic. They can understand how important it is to prevent postpartum hemorrhage, how important it is to ensure access to good treatment and good medicines. Next, please. So, as we all know, equitable access to good quality, effective, and affordable medicines in a sustainable way is a human right. And we feel that we need to pay greater attention to the medicines that we are providing in the area of maternal health, and countries need to invest in human and technical capacity to ensure that WHO recommendations, which are evidence-based, to ensure that the medicines that we recommend are also monitored effectively and continuously by government agencies. Next. So I would like to thank you very much for your attention, and I would be very happy to answer any questions you may have. Thanks. These are the references to the recommendations. So this is the end. Thanks.